All right, 2 minutes until 1 o'clock. We are going to begin right at 1 o'clock, so just about 2 minutes now. More people go in, and it's about 1 minute until we begin. Is 1, so we are going to get started. So welcome, good afternoon. This is the 4th webinar in our webinar series, and today we are lucky enough to have Sally Hess from the CDC. To introduce Sally, I am going to go over a few housekeeping items. All participants have been muted upon entry. At the end of the presentations, we will take questions. I'm going to have you guys enter that into the chat box instead of unmuting you, as there's a lot of background noise. So if you just enter into the chat box, I can relay the questions to Sally. And then just a reminder, as always, the survey must be completed at the end in order to receive your CEU for participation. I would now like to introduce our speaker, Sally Hess from the Centers for Disease Control and Prevention. Sally is certified in infection control and was the manager of an infection prevention program for 25 years at the University of Vermont Medical Center. She did this from 1993 till present. She has been on a variety of platforms at multiple national conferences. Sally's been working as an infection preventionist with the CDC since 2015 and has done great work with the CDC dialysis team. So you may have had the pleasure of hearing Sally present for iPro last year at the July 2016 plenary in Meriden, and we're very excited to have her partner with us again and present for us today. Thank you, Sally. I'm going to hand the floor over to you now.
Okay, thank you, Acacia, for having me today. Thank you for everybody that's on the line. It's a little bit different presentation style for me. I'm used to having that live audience. So, a shout out to all of you. I'm missing you. But anyway, today we're going to look at the impact of infections on dialysis patients, and by reviewing several outbreaks, hope to share with you ways to reduce the risk of infection and improve outcomes for all of your patients. The outline of what we're going to do, we're going to talk a little bit about the impact of dialysis-associated infections, kind of that background. Talk about those recommended practices and the fundamental elements of preventing infections in a dialysis center. And then using a case study revolving around hepatitis C transmission, we're going to talk about trying to understand transmission and the lessons learned from Hep C. And then to wrap it up, I want to tell you about 2 different initiatives that can provide some support your efforts to reduce infections for your patients, and that's the Making Dialysis Safer for Patients Coalition, as well as ASN's Nephrologists Transforming Dialysis Safety Initiative, which is also referred to as NTDS, and that's focused at engaging our nephrologists and medical directors to prevent infection. So why are dialysis patients at risk for infection? If I had my live audience, you guys would all have an answer for this. Instead, I have to give you some clues here. The frequent use of catheters or insertion of needles to access the bloodstream. Obviously, we know that we've weakened immune systems for all of our patients. And then our patients are in the hospital. They go to get that AVG, AVF. They go back, they get infections, they get all kinds of things. So frequent hospital stays and surgery. So what about the infections? What kind of infections are dialysis patients getting, and what are they at risk of? Certainly hepatitis B and hepatitis C, as well as bloodstream infections. Find that Hep B and C are blood-borne viral infections, and they can cause chronic, lifelong disease. So this is not a good thing that our patients are at risk of getting both Hep B and Hep C at dialysis center through something that, as a healthcare worker, we're doing that may not be preventing that transmission, but allowing that transmission to happen on our watch. Keep in mind that both Hep B and C viruses can live on surfaces and be spread by without the visible blood, because we can't see those viral particles. And then the type of infection that we're really concerned about are the bloodstream infections. And you guys, I can guarantee all of you have seen a patient get a bloodstream infection. You know how serious that can be, and you know the treatment and the problems this causes, and the angst that the family and the patient go through. So it's as simple as that somehow we're allowing that bacteria to enter the bloodstream, whether it's through the vascular access directly, catheter, the fistula, or the graft. Some invisible microbes are entering that patient's body on our watch, and we need to make sure that we can prevent that in any way. A bit more specific on the BSIs, the bloodstreams, 1 in 4 patients who get Staph aureus in their bloodstream end up with some really severe complications such as endocarditis or osteomyelitis, both pretty bad things. Up to 1 in 4 patients with an infection, they may die within 12 weeks. So the mortality and morbidity from BSIs is huge. A few years ago, published the vital signs after looking at, what is the risk of bloodstream infections in our patients. So in the U.S., there are 6,000 outpatient dialysis facilities. And I have to say, this is probably one of the numbers that when I first started as an infection preventionist looking at dialysis, I didn't realize there were this many outpatient dialysis facilities. And none of them had an infection preventionist such as myself, or very few did, to actually go out into that center and really bring the arts and knowledge and skill of infection prevention to that center. So they treat about 400,000 people, and that is not going down. I mean, all predictions that I hear is that 400,000 is only going to go up. Of those 400,000, when CDC did this study back in 2008, about 75,000 of those were receiving hemodialysis through a central line. And as you guys all know, central lines do have a higher risk of infection than the fistulas or the grafts. And at that time, CDC estimated that about 37,000 central line-associated bloodstream infections may have occurred in those hemodialysis patients in 2008. So if only 75,000 of those individuals were actually getting treatment through a central line, we ended up with 37,000 central line bloodstream infections. You can do math and figure out the attack rate there. That's pretty high. A lot of our dialysis patients with central lines were getting infected. So when we look at the national burden and we say, okay, how does that compare? We drill down on dialysis, but how does that compare to other settings? At the time that CDC looked at dialysis patients, they also looked at all inpatients in hospitals, and they estimated that 41,000 of those inpatients ended up with a CLABSI. So it's about the same as the hemodialysis. They also looked at the mortality, which was 12 to 25%, and they tried to fix a cost per episode, which was about $4,000 to $28,000. So it's costly. A little bit of an update in terms of BSIs and hemodialysis, as is coming from some CDC work looking at the 2014 NHSN data that's reported from the centers, that perhaps the C rate is decreasing some, about 16,000 estimated CLABSIs, 30,000 all BSIs reported. So is there a nationwide reduction? Are the efforts paying off to prevent BSAs? Also, CDC is a little bit concerned that we've recognized some underreporting. One quick study that was done looked at a 60 to 80% of reported cases. So that's a concern. Are we dropping? Hopefully we are dropping, and hopefully that underreporting is not quite that high. So what is the infection risk for dialysis patients? Both of these are a little bit astounding numbers. You know, when I think of patients that are infected with Staph aureus or MRSA, my guess is that all of you have seen this. The incidence in dialysis patients is 100 times greater than the general population develop an invasive infection with MRSA. That's a pretty significant increase. And for Hep C virus, and we'll talk a little bit more about this, the prevalence in dialysis patients is anywhere to 18 to 14%. So this makes us think, all of this background makes us think that, you know, as healthcare providers, and this includes doctors, nurses, technicians, you know, what is it that we can do to prevent these infections? And on the flip side is, yes, we can prevent many of these infections. And it's really just looking at basic infection prevention recommendations. They're not big and fancy. We don't use all the whistles and the bells. We just need to be reliable and what we know is the best thing to do and do it all the time. Before I go into those standard infection prevention things that we have to go, let me take a step back and look at, you know, how do these infections happen? And I'm going to take way back to that chain of infection, the really basic, you know, how does an infection happen? What has to be there for it to happen? So we have infectious agents at the top there, the bacteria, the fungus, and the viruses. And what is it that we do to break that chain? So for an infection to happen, all these links have to stay intact. But ways of breaking each and every one of these links, and that's what's important for you to kind of take that step back and say, okay, this line, my infection prevention mission is to break as many of these links in the chain as I can. So from the infectious agents, the bacteria, fungus, and viruses, yes, they're there. But if we can diagnose and treat them, they won't be there. So that's how we break that link. The source has to be there. You know, we have to find these bacteria. They have to hang out somewhere. Well, in dialysis are the big source. But in reality, equipment and water is there as well. So how do we break that chain? Well, education and policies are really, really important, making sure that we're practicing evidence-based practices, make sure that the environment is clean, and making sure that we're doing disinfection appropriately, and that that equipment truly does become decontaminated, that it's not able to be a source of bacteria or viruses. And then the next link is the exit. So we have an infectious agent, we have it in a source, but it has to get out of the source to get on its way to cause that infection to keep going on the chain. So for the exit, aerosol splatter, you know, how do we break that chain? Well, hand washing, obviously, but also control of aerosols and splatter. You guys know what happens when blood goes splattering. It goes everywhere, and if you can control and prevent that, you're going to reduce the risk of transmitting infections for your next patient. So breaking the chain of infection is really important. The means of transmission, direct contact, inhalation, or airborne, your direct contact dialysis centers is your most at risk. And what do we do to break that chain? Isolation, disinfection, and there we go, hand washing or hand hygiene again. And then if we already have those four intact and none of those have broken, of entry. You know, do we do things to our patients, our dialysis patients, to allow bacteria and viruses from other places to enter that patient? Oh, yes, we do. If you think about that, central line is an open, wonderful highway for bacteria to make its way into a patient's body. The AVF or AVG, also a wonderful powerful portals of entry. So how do we break that chain of infection? Again, hand washing, personal hygiene, first aid, and then the susceptible host of underlying diseases, immunization. We want to make sure that we can break that chain as well. So in the dialysis section, the risk dialysis patients, if we think of those sources, contaminated environment, equipment, and hands, and then think of that portal of entry, the central lines, the AVF or AVG. And then if we think of breaks in aseptic technique, it's probably multiple chains there. So we'll make sure that we truly always break that chain of infection. When we look at bacteria and we think of them hanging around in the source, how do they really stay in the environment? And a lot of people just absolutely love this grid because it really looks at those bacteria that we hear about, that we see in those bloodstream infections, and we say, oh, wow, where did it come from? Well, it could have come from the environment. It could have come from, we talked about that sources being the people, could be the water. But let's talk about some specifics here. So for staph aureus, which would include MRSA, the skin, it can remain in the environment for 6 days to 7 months. So it kind of hangs around. And keep in mind that staph aureus, 40% of us are colonized on the skin anyway. So it is around. And if you look at enterococci, 100% of us have enterococci in the GI tract. It's a good bug in the GI tract. And we've also maybe colonized with vancomycin-resistant enterococci, and we're not ill from it. We're just carriers of it. If it's out in the environment 5 days to 4 months, it can hang around. And then there's the big daddy of them all, the C. diff, which actually forms spores. And those spores are going to hang around the environment for a long time, up to 5 months. Klebsiella, gram-negative, that can be harbored normally found in the GI tract, again, up to 3 months, 2 hours to 30 months. It can be persistent in the environment. And they have the 2 water bugs, Pseudomonas and Serratia. Both can hang around quite a little while. And then the 2 viruses, Hep B and Hep C. These are bloodborne viruses. Those would be, that is where they are found if a patient is infected with the virus, and then that blood gets in the environment, and the virus can hang around and still be viable for days to weeks. So okay, now we've heard about all the bad stuff. We know our enemy is. What do we do to truly prevent infections? We want to have a program in place. What are the fundamental elements that we need to have on that program? First, we need to have somebody who's accountable for infection prevention. We need to have a structured program, and that program needs to have accountability. We need to make sure that we educate and train our staff. We need to monitor and report infections. And we need to make sure we adhere to standard precautions. And so what are the elements of standard precautions? Obviously, hand hygiene, the use of personal protective equipment, gloves, gowns, masks, injection safety. Are we using aseptic technique? Are we being careful on the way we inject? Environmental cleaning, are we keeping that environment clean? Think back to that chain of infection and how many places that can be a problem. And then medical equipment, are we using it per the manufacturer's instructions? Are we disposing of disposable items? Are we reusing them? And then have we educated all of our staff on cough etiquette, our patients on cough etiquette and respiratory hygiene? So these are fundamental elements of an infection prevention program. These are not unique to dialysis. This list comes from the Guide to Infection Prevention for Outpatient Settings. So you should see in your doctor's office, your dentist's office, but also your dialysis center. This is the basic outline, the structure, the bones for a really good program. So CDC recommends that that's not quite enough in dialysis, that there are actually some additional things that we want to do above and beyond those core elements. So we have 9 core interventions plus 2 recommended practices. And here's the picture of the 9 core interventions, and I know you can't read all of that, but these are all evidence-based CDC recommendations, and the link for that is there. And I know that Acacia is going to forward this for the set to you, so you will have those links to click on and use. So what are those recommended best practices? I always group the first ones into what I call program elements. These are things that you go back to a fundamental program and you need to have somebody accountable for. These are things that don't just happen a day. They don't happen by just including it into your policy. They happen because somebody is saying, gee, we need to have an initiative to do this. This needs to be part of our everyday work, but also needs to be part of our infection prevention program. So that's the one thing is surveillance and feedback. Surveillance using the NHSN program, and then making sure you provide feedback to the staff members. And hand hygiene and glove use observations, getting out there and watching what's actually going on at the bedside and feeding that back to information, engaging some patients is on that also. Catheter and vascular access observations, really important, and I'll talk a little bit more about that in a later slide. Patient engagement and education, making sure that they get it too. They can be advocates to ensure that they do not get an infection. And staff education and competency, and making sure that you're assessing that competency every 6 to 12 months, as well as on hire. And then catheter reduction, your Bill First catheter last initiative. And then the next ones are what I call the patient care elements. These are the things that happen at the bedside that are part of the policy and should be happening 100% of the time. So the CHG alcohol for exit site sepsis, the method in which you actually scrub the hub to make sure that you truly are disinfecting the catheter hub cleansing, the catheter exit site care using an antimicrobial ointment, or some of you may be actually using an antimicrobial disc, and making sure that the environmental surfaces, your routine station disinfection is being done appropriately, as well as safe injection practices. So the recommended best practice is dialysis center. What happens if you follow the CDC protocols? After these were first published back in 2009, CDC did a small collaborative demonstration project with 17 centers, and said, okay, does it work? Is that those 9 elements, the core interventions, will your bloodstream infection rates go down? And what we found was that 30% reduction in bloodstream infections, a 54% reduction in the access-related BSIs, and that the individual facility level impact was significant. I can say that I was at some of those facilities and we got to 0. It was quite the separation. And then we had an infection. It was devastating. There was a follow-up study that was done looking to see if these centers could sustain it, and there was data that demonstrated that it was sustainable 48 months after the intervention. So implementing these methods really is important. It's been proven. So what are some CDC resources? This is the John Jernigan video. Hopefully you guys have all seen this. It's 11 minutes. It's wonderful for staff education. It goes through all the standard practices. And also it's good for patient education. And then I'm sure you've seen the checklist and the audit tools. This conversation starter is the new patient engagement, and that's available on the CDC resource. I love the jigsaw puzzle here because you can pull one of these for each month and provide patient and staff education on that element. And the checklist, again, the checklists are great to be used for both staff education but also patient education so they know what to be seeing. And then the patients with catheters, the 6 tips, that's a great way to hand out to the patients. Moving on, that kind of set the base. That's what you should have in place. But let's look and see what really happens and use Hep C as a case study to say, oops, things don't always go perfectly. A little bit background on Hep C. It is a bloodborne virus, and keep in mind that the concentration of the virus is highest in the blood. It's low or undetectable in other body fluids. And it's spread by percutaneous exposure. In other words, it has to go through the skin. So a needle stick is a classic. But contaminated medical equipment in dialysis centers and then open central lines, or open wounds is another way that it can actually gain access to the body. So the acute infection, interestingly enough, only about 20 to 30% of individuals actually have symptoms of infection, the fever, fatigue, etc. Most people are unaware of the infection. But once infected, most people develop chronic hepatitis C infection. The only way to determine if someone is infected is actually do the test. You can look for the antibody to hepatitis C, or you can look for the RNA virus, either qualitatively or quantitatively. So, keeping, unlike Hep B, Hep C, no preventive vaccine exists. But there are costly and really curative treatments for chronic HCV that are available, which is wonderful because it's really changed the whole scope of HCV infection. Now we will know for sure if somebody's infected because these direct-acting antivirals, which are old medications, and they work directly against the virus to make sure that it doesn't keep multiplying inside the body, so really are effective. So unfortunately, without treatment or cure, about 20% of individuals with chronic HCV, they'll go on to develop severe liver impairment. And of those, 25% will die prematurely from liver disease. So it has some significantly bad outcomes. We need to know when people are really infected with us. In the U.S., about 17,000 deaths happen annually related to Hep C. What about our hemodialysis? I already mentioned that it's a pretty high prevalence that compared to the U.S. general population, which is 1.6% prevalence of Hep C, and hemodialysis patients is as high as 8 to 15%, so 6 times greater than the general population. What are CDC's recommendations? From the 2001 MMWR, CDC recommends screening upon facility admission for look antibody, as well as every 6 months to ensure that conversion and exposure hasn't happened on your watch. Just a note here that if you have Hep C infected patients, you don't need to continue to screen those, but they should be referred for the recommended care and perhaps treatment. Susceptibility in healthcare. How are we actually transmitting it? Again, parental exposure has to go through the skin, injection or break in the skin. Really ever happen on our watch? I think so. I really, truly don't believe that in healthcare we should have any transmission of blood viruses. So if we bring that back to strict adherence to infection control standards, it should be adequate to prevent that infection. But there are factors contributing to this patient's actually getting hepatitis C on our watch. We'll have to probably do this list. Large number of patients treated in the same time in the shared space. There's lots of opportunities for blood contamination, the environment. I had to put this chair up there because I can't tell you how many times I've seen a rolling stool that people sit on with a pair of dirty, they've got gloves on, they've done some work with the patient, they've touched the machine, their gloves are potentially contaminated, and then for some reason they have to sit down on that chair, adjust the lever with the contaminated gloves, and then that chair never, ever gets clean. It means is a fomite that has multiple patients' blood on it. I always wonder. Anyway, that's just my personal pet peeve, is rolling stools that go from patient to patient, station to station, and inadequate infection control practices. In other words, it never gets clean. We talk about the environmental stability of Hep C. You guys all know that blood contamination on surfaces is frequent, and we mentioned from that table before that HCV can live in an infectious state for 16 hours or longer, so it can hang around, and there's a lot of contaminated surfaces that may have Hep C on them. So to illustrate that a little bit more, there was a study that was done in the Netherlands that was inspired by CSI. They had a cluster of new Hep C infections, and were identified in a hemodialysis unit. So they implemented strict infection control measures. They wanted to assess the role of the environment, and they used some forensic luminol to detect residual blood. Keep in mind, it had bumped up their measures when they did this testing. So if you look at this with the light out, the handle of the cupboard, couldn't see any visible blood or body fluids. With the luminol, you saw it on the handle. In the floor, again, the splash and splatter. High surfaces, they again looked at the control of the hemodialysis machine. There was no visible blood, but if you looked at luminol, it certainly was contaminated. And who knows how many different patients of blood that was there. So lessons learned from outbreaks. Okay, you guys, look at this picture. How many of you, in perspective, does your unit ever really look like this? The whole picture? No, absolutely not. Because you fill its fishbowl with what? With people, with patients, with body fluid that doesn't always stay where it needs to stay. You've got visitors, you've got activity. It gets confusing there. So anyway, what about outbreaks? Hepatitis outbreaks from 2008 to 2015 that CDC looked at. For Hep B, there were 23 outbreaks, 175 outbreak-associated cases, and of those, and as a result of those exposures, over 10,000 individuals were notified for screening. But for Hep C, same period of time, 33 outbreaks, more 239 cases, and with the number of at-risk persons that were notified for screening, almost 100,000 individuals. So really big time there. And notable that hemodialysis is the single most common healthcare setting for HCV outbreaks in the U.S. I'm not sure I really appreciate that until I was looking at this data, that it really is Hep C and hemodialysis that's unfortunately linked together. Hemodialysis-associated outbreaks for Hep B during this period of time, there were no outbreak cases reported for Hep B, but for Hep C, there were 18 outbreaks with 2 or more cases. These in 18 different clinics in 9 states and 96 outbreak-associated cases. And there were almost 3,000 persons identified. In addition to those 18 outbreaks, there were 7 single cases reported in 7 different clinics in 5 states. So it's widespread. It's not in a particular state. This is just a table that is an example. I don't expect you to read this, but under the breaches identified or suspected mode of transmission, what I want you to take away is there's lots of elements that when CDC went in and invested these outbreaks with the states on, it wasn't a single smoking gun. There was lots of things that were going wrong. So multiple lapses. There were some common themes, and we're going to go through each of these 4 common themes. Try to drill down so that you,
Just to 31.
Okay, and we're on slide 32. So go fast now. Okay, so some of the common themes, patient overlap in space-time. So here we go. This was a cluster of infections. This was one center. I'm going to show you 6 slides, but they actually had 3 clusters of hepatitis C acquisition. There were 3 different strains of hepatitis C when CDC did this investigation. So the first cluster was in, you can see that chair 18, the blue chronically infected patients, Monday, Wednesday, Friday, first shift, Monday, Wednesday, Friday, second shift, 2 acutely infected patients. Say hi. So prominently here. The next one was the cluster 2, so just the same center, just a different strain of hepatitis C. This time, a chronically infected patient was up in chair 28. It was a TTS first shift patient. And look at this one. They found the same strain, TTS second shift, actively infected patient. Same. Wow. And then the third cluster that they were able to look at, again, was a TTS first shift patient, chronically infected patient sat in chair 17, and another acutely infected patient in chair 18. So my question is, isn't it time to get serious about preventing infections? Would you willing to undergo treatment in this station? Find this patient under typical conditions. And they're doing the right thing. They thought they were clean. But the thing was getting missed with these infections happening. Next common theme is breaches in medication prep and administration practices. Make sure that we're not preparing meds in potentially contaminated areas, that we're not using mobile medication cards, that we're, unfortunately, some individuals in this case were not wiping the injection ports prior to accessing. So this is a picture of what's wrong with this picture. So you figure out where they're actually doing the med prep in this picture. Would you do med prep in this picture at all? I'm hoping not. But that piece of paper was, which is immediately adjacent to the blood specimen processing area, was where we're doing the med prep. So more about medication handling and some of the questions that you need to ask yourself. Where and how are medications prepped? Are the exceptions? Is for your nurses the same as your workflow for your tech? Or if you administer different medications, is the workflow actually different? So make sure you look at both workflows if you have two workflows. Where are medications stored? Do you ever see a patient like this one? How are medicine infusions administered? Is there consistent aseptic technique? Are injections always disinfected and moved from one station to another? So I have one other yellow circle here, even though it doesn't have to do with medication, but it's kind of what's wrong with this picture. There you see a multi-use roll of tape just sitting back there. I'm wondering how many patients that I've gone to with a pair of gold hands that may have been contaminated, and then the roll of tape is contaminated. So that medication preparation. This still says new CDC tool. I have to say it's been out a few years, so it doesn't necessarily feel new. I'm hoping that it doesn't feel new to any of you. If so, here we go. So we want to make sure that you're preparing your medications in a clean room, preferably a whole separate room than within the treatment floor. It needs to be free of contamination. Make sure that you're storing your multi-dose files in a designated clean area. And make sure you read the small print. Look at this. This is really important to read that. One of the recommendations is to prepare your medications close in under administration. So how many of you are still doing your whole run before the patients get there? You draw it up and have it all ready even before the patients. That's way too far ahead. Ideally, you want to draw that up right at the time that you need it. Transport those meds directly to the station where they'll be delivered. This is the medication administration checklist. Use aseptic technique. That's all I have in that one. Okay, so on to the next common theme, which is breaches in environmental cleaning and disinfection practices. Ensure that surfaces are wiped down with the patient. I want to make sure that they're not wiped down with patients still at the station, because that's one of the common themes. And obviously, the rush turnover process is another common theme. So again, a series of questions for you to ask yourself is, how cleaning and disinfection performed? Are you using the appropriate disinfectant? Are all surfaces truly getting wet? Are you getting surfaces at the station? Prime bucket, if you have containers that are attached to your station, do you actually clean those as well to avoid that splash and splatter from remaining on there to the next patient? Proper surface disinfection achieved between patients? Are the out to dry? I can't tell you how many times I've seen a station be cleaned, and while it's still wet, somebody brings that next setup and sets it right at that station, right into the wet surface. So that surface isn't disinfected and it's still contaminated. So obviously, reliance on visible evidence of contamination is a real problem. CDC has developed this summary guidance. If you have not read this in the last 6 months, I would strongly recommend that maybe that's one of your single action follow-ups for this webinar is to read the environmental surface disinfection notes for clinical managers. This has some really good tips. It includes considerations for selecting the proper disinfectant and to determine the correct dilution for routine use, and kind of gives sense of what CDC's expectations are here. Also establishes the procedure for the dialysis station disinfection. Reread it and make sure that you really are on board with that. So it has a nice discussion on the use of post-treatment observation areas if you're challenged by getting that patient out of the station. And it talks about the key elements for staff training on disinfection procedures. Make sure, do a checklist. Are you actually educating your staff on all those recommended elements? And then make sure there's also a list of the necessary supplies that individuals have to have access to. So I would encourage you to reread that. And then take a look at, if you're not already using the checklist for the routine disinfection of the station, I would again look at this. Keep in mind that this is broken into two parts. Part A is where you need to remove the items and prepare the station. And part B, to complete this, the patient must have left. So this is a true disinfection of the station after the patient has left. And you all those surfaces, and they again visibly wet and need to be allowed to air dry. The bucket is something that I see repeatedly missed time and time again. And then obviously you need to wait and not bring that set up to the station until all things are dry and everything is finished. A little bit, going from this C outbreak, I want to bring two other outbreaks to light, and that's C. diff and VRE. There was a C. diff outbreak in a fairly small dialysis clinic, 37 patients in the clinic, 8 of which developed C. diff infection. What's interesting is they had a pretty high rate of antimicrobial use, 44%, as well as 35% had been hospitalized. But this is a pretty big outbreak. For those of you that have even had one C. diff patient, I'm sure you can't even imagine having 8 C. diff patients infected. Interestingly enough, one staff member also developed C. diff infection. Put in place aggressive control measures that actually were successful at detecting new onset of C. diff cases. So I just wanted to bring this up kind of in review of the context of the outbreaks. They implemented contact isolation for infected patients. They had to wear gowns, gloves. They implemented hand washing with soap and water after caring for the patient. Modified bleach solution, they bumped up to the 1 to 10 use for all disinfection, and they increased the attention to actually kind of attention to detail to make sure they really were doing a good job and making sure that there really was wet contact time, that those C. diff spores and viable organisms really were getting killed by their process. So just a reminder that sometimes things such as C. diff and the horrendousness of it reminds us that we need to be consistent and always adhere to the practices that we know are the right practices to be doing all the time. It's really important to keep that on our horizon. And the VRE study is actually, remember, vancomycin-resistant enterococcus is a strain of enterococci, and this is an Australian study that looked at 7 patients as well as 15 healthcare personnel who took place. They looked at 26 different dialysis sessions. What they did is they took patients who were colonized. They were VRE carriers. They weren't infected with it. They were just colonized. They were fecally continent, so they didn't have diarrhea. They were walkie-talkie normal hemodialysis patients, but they just had this particular organism that was, maybe kind of that sentinel that they could watch and see if they could recover it from the environment. So they cultured various surfaces after each treatment session. Prior to the treatment session, they had ensured that all surfaces were free of VRE, so that they knew that if the VRE was there after the treatment, it was really attributable back to that patient. So here's what they came up with. They cultured all of these different locations, and the VRE contamination rate was highest for the dialysis treatment chair, health care providers' gowns, patients' ungloved hands. So 4% of the patient's hands were contaminated with VRE. Now, think where that VRE came from. Is this fecal transmission that happens in the dialysis chair where we don't really even know about it? So of this are pretty high. So these are continent patients. And the chair, the gown, the patient's hands were significantly contaminated. So you have to think about what is it that we're spreading around the environment and how do we make sure it's not there anymore? Well, that's the challenge to proper environmental disinfection. So sometimes that's a complicated station. There's no physical barrier between stations. There's frequent blood contamination in surfaces, and we just talked about frequent contamination from other areas, as an example from the C. diff and the VRE. Staff feel pressure to turn over stations quickly. And all the time, it's easy to miss even entire stations. I've been observing in a lot of centers, and sometimes I've actually seen people who two techs partner up to do a station, but then one tech gets distracted and the other tech thinks that station's been cleaned, comes back, starts the machine, and it's never even been cleaned. So multitasking is really, really a concern. We need to have that straightforward process. Contamination of clean surfaces. I've seen those contaminated pillows, put back on clean surfaces multiple times. Shared computer charting stations with treatment stations. Those, I'm not sure if keyboards are considered to be clean, dirty at your center, but rethink about that concept. The fourth comment, yep.
140.
Okay, we're going to fly now. So lack of physical barriers or meaningful separations between stations. I know you guys all know about that. And a clean versus dirty workflow outside of the station. When someone takes those lines off and they take them to the red bin waste in the center of the unit, and then they don't immediately remove their gloves, are they putting other surfaces at risk of contamination? Take bloods to the lab refrigerator. Watch how that workflow goes. Watch how your soil linens are handled to see if there's any contamination. So in summary, some HCV and outbreak lessons that's prevalent in hemodialysis patients. It has some serious outcomes. The infection is often asymptomatic. And remember that we need to screen to detect on admission in every 6 months. It should not be happening, but there's documented transmission between patients. And we need to make sure that we're adhering to infection prevention practices 100% of the time. Last January, or a year ago January, CDC published the CDC Health Advisory urging providers to implement 4 things to prevent HCV transmission. Want to assess your current infection control practices and the environmental cleaning. I'm going to talk briefly about the ICAR process, and this is something that can help with this number 1 thing. And then address any gaps. If you identify anything in the ICAR, that assessment that you can look at, then that needs to be brought back to the staff members and training needs to happen. You need to be screening your patients according to the recommended protocol. And if you do see any Hep C transmissions, CDC recommends, all of the states require you to report that to your state and local health departments, so make sure you do that promptly. Going forward, we've learned lots from our outbreaks, but what else can be done to help? So I'll talk brief about these 4 things: the infection control assessment and response to ICAR, the reuse of the CDC audit tools, and the Making Dialysis Safer Coalition, as well as an AS initiative. So the ICAR process, and I know that Acacia is getting out there. She's doing those site visits. She's helping you with user observations helping with the feedback and follow-up. So make sure that you keep that process live and active, because it really is that fundamental way to figure out where are opportunities for improvement. What is it that we can do on that? And use your checklists and audit tools, and make sure that you're assessing practices and that using that information to improve practices, and then it's a continuous circle. You don't do these to do them and report to somebody. That you make sure that you use it as an opportunity for improvement, and that you really look at each element. You may do 9 out of these 10 elements perfectly, but that first one that you're not doing that is what? Not breaking the chain of infection, allowing that chain to be completed. So make sure that each and every element you have full compliance with. The value of auditing and the CDC recommended practices, keep in mind that it promotes and reinforces the recommended practices among staff completely and correctly. So 100% of the time it provides for highly reliable care. We want to make sure it's done correctly each and every time. And then just as a reminder from that CDC study that showed 54% reduction in access-related BSIs when the CDC recommended practices had been implemented, and that was sustained for up to 4 years following implementation. So I'm just quickly, boy, is that bright. If it didn't wake you up, then wake up now. But anyway, introduction to the CDC Coalition. The Best is Safer for Patients Coalition is a new partnership of organizations and individuals, of anybody who has anything to do with hemodialysis, and is the goal of promoting the use of the CDC core interventions to prevent bloodstream infections. So, just that you called in and listening, still listening, means that you are a vested part of this. So I encourage you to become a coalition, and I'll talk about that in a minute. So the goals are to facilitate implementation and adoption of the core interventions, to increase awareness about the core interventions, but also, I think more importantly, is to have the opportunity to share experiences and findings through collaboration with other coalition participants. So we really want it to be all about talking about infection prevention in the dialysis centers. So who are the participants? There's a group of core leaders in infection prevention, and then there's partners that are organizations, and then there are members who are individuals such as yourself. This is just a quick link at some of the coalition partners. Like to become a member, keep in mind that members are individuals, such as nurses, techs, anybody who's listening on the phone has the opportunity to become a member, and you can just either Google the CDC Dialysis Coalition, or there's the link right here on this page as well. I'm not going to read through these activities. You'll have that slide set, and you can study that if you're interested in knowing specifics. There's a listserv distribution list. We do have newsletters that go out. I think our third one just went out. A lot of educational webinars. It just did earlier this week. And the recorded webinars, both of those would have CEUs attached to those. It's an opportunity to hear about cutting-edge prevention activities, learn from experts in the field, as well as hopefully share your experiences in networking. In addition, you can get free coalition materials and resources going to the cdc.gov/pubs, and that's where you can get all of your audit tools, your checklists, and some of the other things as well. I also wanted to mention about another new initiative that is ASN, the American Society of Nephrology, and that's partnered with CDC in developing this Nephrologist Transforming Dialysis Safety Initiative. I am so excited about this because in my live in-person presentations of this, one of the questions that's always asked is, how do I engage my medical director? How do I let my nephrologist know about infection prevention? Well, this is how you do it. They are going to be engaged to be leaders on infection They're going to be the point is to target 0 infections, and the series is going to get kicked off on May 23rd with our first webinar and talking about where do we begin. And this is engaging and empowering medical directors as well as nephrologists and other leaders in the dialysis centers. I wouldn't hesitate. Go on to the site, ASN site, and free registration. You can register even though you're not an ASN member. And webinar 2 is in September, looking at the antimicrobial stewardship as well. What are the next steps? So we can protect patients from potentially deadly bloodstream infections, but can't do it without you. So I encourage you to go in and look at the Making Dialysis Safer for Patients Coalition, become a member, and more importantly, to share and to network. So that is the end of my slide. So,
thank you, Sally. The chat is now open, and we have about 7 minutes. It's 1:53. But thank you so much, Sally. I especially love the case study that really highlights, environmental impact and the transmission of that hepatitis C, which is, obviously a scary situation. But I really love how that kind of highlights that.
Thank you.
It's open. I did leave a message a few minutes ago to participants that they could ask to that, and so far don't have any questions, but I can hang on the line until the end of the webinar. So just a reminder to everyone to use that chat box to ask Sally any questions. So she is looking for the slides. Linda, I am going to be sending these out to everybody tomorrow. So you'll be on that email list, and I will make sure you get them. And Peggy, Bush, are the folks, patients involved? And that might be a question to the facility. Patients involved with the coalition, is that what you're referring to, Peggy? Sally, if you saw anything involved, if you saw anything in terms of getting patients involved.
That's another webinar is talking about getting patients involved, but I think each and every one of you have patients that are could be advocates. I think I shared with you, and I don't remember what slide number it was, but there is that one document, the conversation starter to prevent infections in dialysis patients. That's a document that I know a lot of centers are starting to roll out. Can I just go backwards and show? Okay, I can find it. I can pull that up. Because I think it meant that people are starting to use and truly has a lot of nice questions on it that can help Peggy's question right here. Oops. Conversation starter, and that you can get off the website. It was developed in association with AAKP, and it talks about questions about immunizations. It talks about infection prevention. So it just starts that conversation. And I think, as anything, if you get a few patients that are advocates, that will spread, allow those patients to talk with other patients. A lot to be said with trying to get some patient advocates and patient engagement. So, other questions?
One that just came in. If the patients have a very difficult time standing or using the sink, is there a suitable alternative for them to use to wash their hands, but more importantly, their access when they enter the clinic?
Yeah, you have to accommodate whatever works the best for the center. If they really can't stand at the sink, can you bring them a washcloth, a wet washcloth and soap, that would be wonderful. That would be the ideal. If you can't do that, I have seen some centers use the alcohol-based hand sanitizer. I still think soap and water in some way is great. There's another product that is like, I believe brand is Pause, but I'm not putting anything here. It's just kind of like what you use after you eat ribs at that wonderful steakhouse to clean your hands. So you can provide that as well, to clean that. But I would love to see it like use soapy washcloth to wash the hands. Might not be realistic for all places. I understand that. Okay, other questions? We don't need coming in yet in about 2 minutes of 2. So if anybody has any last-minute questions, make sure to come in. Facilities are using the Pause if they can't use the soap and water, whether the patient can't wash or they're not doing the soap and water on the washcloths or paper towels for the patient. So they are kind of using that alternative already. Okay. Yeah, that's a product I've seen pretty widespread. Yeah. Okay, so if nobody has any other questions, feel free to log off, but just make sure you take that survey in order to get your CEUs. We will be distributing the slides tomorrow to everybody who participated. And thank you again, Sally. You always do a great job, and I know this information was particularly valuable to all our project participants. There's been a lot of things you talked about are a lot of the gaps we've kind of identified at the site visits. So I know this was a very valuable webinar, and I'm looking forward to hearing our feedback on it. Okay, well, thank you for having me.
Thank you. All right, I am going to end it now. It's just 2 o'clock.